Morning, everyone. We are live on Saturday. It's a roundtable session with the experts. The topic is risk of cardiovascular problems in the post-COVID patients. This is a 98th session, and I would like to invite Dr. K.K. Kalra, former CEO of NABH and Director for Heart Care Foundation of India, to take the session forward. Dr. Kalra, over to you.
Yeah, thank you, Saurabh. Good morning to all, and I welcome all the participants to this 98th weekly roundtable expert group session of Heart Care Foundation of India. Before we start today's topic, I would like to give a brief update on COVID situation around the world and in India. Let me share my slides. So all over the world, globally, as per WHO weekly report, this week, ending on 17th of this February, and this data is up to 15th of February, all the 6 regions except one region, that is Western Pacific region, all regions have shown a declining trend in the world. And overall, on average, this week compared to the prior week, there was a 19% decrease in new cases, but deaths still there was average 4% increase. The highest number of cases were reported from Russian Federation, Germany, which was similar cases as compared to the prior week, United States of America. Although this week there was a decrease in new cases, almost a decline of 43%. Brazil, again, there was some decline, 19%, but more cases were reported from these countries and France. Death, when we see, maximum were reported from United States of America, India, and Brazil, Russian Federation. There has been some increase or decrease in some cases in all these regions. If we see the Omicron, as per the report all over the world now, as per genetic sequence and report by the GISAD, 98.3% cases being reported now are from this Omicron variety. And Delta is only now 1.7% all over the world. Now we see the lineages. There is some difference. Omicron has different lineages, like Pango lineages BA1, BA1.1, BA2, BA3. It is a BA2, which is now increasing all over. The prevalence of BA2 among the sequenced Omicron cases globally submitted to this joint forum has been steadily increasing, reaching 21.09% in the 5th week of February 22, as of 5th week of this year 22. As on 14th February, 10 countries reported a dominance of BA2 more than 50%. These countries are Bangladesh, Brunei, China, Denmark, Guam, India, then Montenegro, Nepal, Pakistan, Philippines. However, there are differences between regions observed, with the Southeast Asia region reporting the highest prevalence of BA2 among the Omicron sequences, that is 44.7%. And region of Americas, they are having the lowest BA2, only 1%. In India, if you see, in the as on data available on the website, as on 18th February, so this is 24 hours old data, 25,000 920 new cases were reported and 492 deaths. And vaccinations, now 174.64 crores doses has been administered. In this week, as per WHO weekly WHO India report, ending on 15th February, almost all states have shown a decline in cases. And largest decline was reported from Karnataka, Andhra, Pondicherry, and the other Haveli. And 17 districts have shown some increasing minimum some numbers in new cases. Apart from 8 districts, 3 in Nagaland, 2 in Arunachal Pradesh, and 2 in Manipur, and 1 in the other Haveli. And our district has reported 1 or more than 1 COVID case during the last 7 days. Maharashtra has reported the highest number of COVID-19 deaths overall, followed by Kerala and Karnataka. In the past week, India reported 5,296 deaths, of which the highest were from Kerala, followed by Maharashtra and Karnataka. This is regarding immunization. This is a 1 week old graph. Almost now, when we see in the over 60 years, 18.7% have received their precautionary dose, that is booster dose, and almost 45 to 60 year age, 2 doses has been received by 84.3%. Even the younger age group, we see 15 to 18 year, when last year we started the immunization against COVID, 63% has been received this first dose of their COVID vaccine. So South Africa, from where the Omicron started, which is now spread to all over the world, still they're showing very good now. It's a declining trend, which continues. And Germany still, for last 2-3 days, it has shown some decrease. Otherwise, it was pouring cases. India already we have seen. Russia, yes, definitely still very high number of cases on 17th. On average, almost 1.78 lakhs per day cases were being reported. United States, definitely for last few days, it has a definite decline trend. But still, the cases being reported on average per day, they are more than 1 lakh. As United Kingdom, again, also is now downward trends, but cases reporting per day, even this week also on average, almost 50,000. France is showing decline, but cases still on average, weekly average, 93,000. Nepal is definitely now declining, and only 483 cases have 7-day average. Pakistan also showing downward trends. Bangladesh also. On average, there are around 4,500 with the weekly average cases. In states, if we see in India, state-wise, definitely Kerala is now on declining, and only 11,996 cases being reported. And last 24 hours, Kerala has reported 8,655 cases. Tamil Nadu, the last 24 hours had reported 1,252 cases and 6 deaths. Mizoram has reported 1,119 cases. Delhi has reported 737 cases and 5 deaths. So this was regarding the situation of COVID abroad and in India. Now over to Chair Dr. Ashok Gupta.
Thank you,
To
Dr.
introduce
Kalda.
the speaker
Thank you, Dr. Kalda.
and
Thank you.
invite me.
Thank you, everybody. Indeed, it's a pleasure for me to invite Dr. Iqbal Bagarsawala, whom I said we know each other for almost 40 years. And he is one of the most trusted names in cardiology and preventive cardiology. Indeed, it's a time for us to learn from him how to prevent and what is the why. I mean, there are 2 questions which I have which came to my mind before suggesting this topic. During the COVID, were the cardiac patients being ignored because of the load of the COVID was so high? many of the patients which were cardiac element and the incidence of cardiac element pre-COVID was so high, suddenly all they disappeared. And most of the death which I have noted in Bombay Hospital and other places were post-COVID recovery because of cardiac element. So I think Iqbal is the best person to guide us what should be way of looking at these patients. Over to Dr. Iqbal Bhagat.
Thank you, Dr. Ashok Gupta. Other respected colleagues, Dr. Kalro. I have had the misfortune or the good fortune, as I would say, to be associated with COVID care right from its inception, because Saifi Hospital was converted into a COVID hospital right at the beginning. And over the period of time, I've had the opportunity to see all the strains of the viruses as they happen, and got a first-hand opportunity to see how the virus behaved, because this was a new virus, and for every one of us, it was new learning. Now, at least during the first wave, we realized that out of every 100 patients that got infected, 15% of them would require hospitalization. And of the 15%, maybe a very small amount would require critical care. In both the waves, the number of patients that required hospitalization was about the same. And it is the natural progression of the illness that guided us to decide which are the patients we will. Interestingly, in viral infection, that periods were the same 5 to 8 days. After the 5th day, to those critical 15% that were infected. A good ballpark figure.
I think let us stop our videos.
Yes,
that bandwidth can be used for.
That's what I was thinking. We can stop the video. And yes, Iqbal, yes.
So it was these 15% that we were watching very carefully over a period of time. And we realized that one very good indicator that we had at our disposal, number one was the pulse rate of the patient, and number two was the saturation. If any of the hospitals had the good fortune of having a CT scan available with them, a good indicator was the CORAD score. Now, a lot of patients, when they were not having fever, if the pulse rate rose above 100, 110, it was an indicator that this patient had early hypoxia, which was being physiologically compensated. In the presence of tachycardia, and if we observed the CT scans, we correlated that those that did not have problems had CORAD scores less than 4 or 5. But those that ran into trouble were the ones with a CORAD score of 11 and above. So that became a good indicator for us to be vigilant. Now, the first, anybody with a CORAD score of 10, 11, 12, 13 was clinically into hypoxia, and that was corroborated with the pulse oximeter, where if the normal pulse, the saturation of the patient was 97, 98%, we used to take a 5% drop in the saturation levels as a good indicator to tell us that this patient is likely to get into trouble. Now, out of those 15% that came to us that required hospitalization, a good 20% of them, somewhere down the line, would develop cardiac symptoms. And the cardiac symptoms depended on some multiple factors that the viral infection was creating. The first kind of problem that the infection was creating was related to SARS, which was hypoxia, secondary to lung involvement. Like I mentioned, if the CORAD scores were 11 and above, some minimal lung involvement has already happened, and that would be the cause of the hypoxia. So earlier symptoms were hypoxia related, which would be just simple tachycardia, breathlessness. In somebody who had pre-existing comorbid conditions like diabetes, blood pressure, in particular, we were observing the obese patients. or pre-existing cardiac anginas, they precipitated with angina. And then angina would then progress to either end-STEMI or STEMI. Now, the STEMI and the end-STEMI was a new complication that was created because of the virus. That was because of its prothrombotic nature, by virtue of creating inflammation in the vascular system, both in the arterial and the venous systems. And these patients, by virtue of their prothrombotic predisposition, would land up either with either pulmonary embolism or in systemic embolization, whereby these patients would then land up with infarcts or end-STEMIs. The most dreadful of the whole sequence was those patients that developed myocarditis. That's because of the inflammation produced. Now, interestingly, this virus would produce involvement of each and every organ of the human body. We have seen almost presentations of all our systems where the virus produced involvement all the way from the brain to the kidney to the liver. Each and every organ was somehow or somewhere or the other infested with the virus and producing symptoms, which were of a much milder nature. But what was creating big havocs was in the respiratory system and in the cardiac system. We used to have patients coming to us with acute pulmonary edema that was secondary to viral myocarditis, which otherwise the patient had no previous symptoms. We heard some of our colleagues mentioning about young patients dying, and these were the patients who would have sudden deaths. If this condition was not diagnosed early and aggressive treatment was not given, they would run into trouble. The commonest presentation they would have is, like I said, a pulmonary edema, and some of them would land up with cardiogenic shock. If the institution had facilities for ECMO, some of us were able to salvage some of those patients, where despite everything that we did lose a lot of them in the progress of the infection. Because of the inflammation, there were a lot of conduction defects that we saw, all various kinds of conduction defects from simple first-degree heart blocks to complete heart blocks. And that also contributed significantly, because if it was produced acute in onset, it would then produce all kinds of systemic presentations of cardiac failure, hypotension, and otherwise. So with that brief introduction of everything that we could have probably seen, we have seen in cardiology, all related. It reminded me of the earlier days of my practice when we used to blame when syphilis could produce anything and everything in the human body. I think this was a replica that we saw, that COVID could do everything and anything to the human body and catching each and every organ of our body. So with that brief preamble, I would throw the floor open for any questions that anybody wants to ask into specifics of any particular kind of cardiac presentation that we're talking about. Thank you.
Thank you, Dr. Bagarsawala. And now I keep the floor open, invite comments and the questions. And I will start with the question. Now, as Dr. Jamkar has mentioned, that the incidence in younger people also have become much more, and we are noting some of these patients. So what was the fate of the patients who had a previous cardiac element? They contracted COVID and they recovered from COVID, but then they succumbed to the aggravated condition of cardiac element, including myocarditis, which you said. So is there any way, now having learned the lesson from wave 1 and wave 2, would you recommend these people to be on preventive side so that wave 3 and wave 4 can not be so lethal for them, particularly the patient with the element?
So here I would refer to the patients whose CORAD scores were 16, 17 and above, sir. A large number of them would have a significant lung involvement. And interestingly, the patients that we followed over a longer period of time, the recovery has been excellent, but the duration it has taken to recover has been 3 months or more. So those younger patients where lung involvement has happened, and one, if they already have a pre-existing cardiac condition, they need to be very, very careful. No aggressive physical activity to be done. They need to make sure that if they are smoking, they must stop smoking. They must keep their blood pressure and their sugars well under control if they already have a pre-existing comorbid condition. And for these patients would be able to get themselves out of this mess till they wait for the lung conditions to revert, the hypoxia becomes less, and gradually they may be able to get back to the normal way of living. If anything, that if these are not followed or things go wrong during this process, then we've had fatalities during the journey also.
Thank you. Dr. Jamkar, Professor Jamkar.
Yeah, there is some report circulating which pertains to, I think, some publication that cardiological complications of Omicron be very high, and I think they are monitoring. So that is only single report which has come on say social media or something. So what about future cardiological complications of Omicron?
So everything now depends on, unfortunately, the first wave was okay. The second wave was bad. The third wave, I don't know at this juncture whether I can take the liberty of saying it's probably come as a blessing, because the morbidity and the mortality that we've seen with the third wave is far less, and a lot of people have already had a chance to get themselves naturally immunized. But if the virus goes through another mutation and we have a strain which is bad, then I think we need to be ready for the fourth wave. But if that does not happen, we could be a little more relaxed. Just like I said, those that develop myocarditis, either from the second or even as the third wave, where there are exceptions, then those patients need to be followed up, and the standard care that we offer of anti-inflammatory drugs, ARB, ACE inhibitors, diuretics, and rest, we need to continue with all of them for these patients who have myocarditis. That would be what I would be vigilant about.
Thank you. I have a question, Iqbal. Right? We know that the post-COVID recovery takes long time. Lung fibrosis, which sets in after recovery, is there any increased incidence of cardiac complication in the post-recovery period? I mean, what is the incidence of patients, those who are healthy before COVID, and they have developed cardiac element during the process of recovery, post-COVID recovery? Has it changed the some scenario?
So like I said, some of them have persistent heart blocks. Some of them have persistent myocarditis with low ejection fraction that remains. And those with a good amount of lung injury, where the hypoxia remains for a longer period of time, you realize that won't come up unless the patient requires, they need a lot of oxygen support during the entire recovery period. That is this group of people that we have noticed that require a lot of careful evaluation and care in the long run, after of which 50% of them recover, 50% of may not recover also. So it may become a long-term problem for them in life.
So what prophylactic and preventive steps you will suggest for this group of people post-COVID recovery and cardiac element?
So I will go, for that question, I will go back to the natural level. The critical time, like I mentioned, was between the 6th and the 10th day. We were using some markers to decide what state of the inflammation the patient's condition was. We were routinely asking for a D-dimer, for a CRP, with the idea the D-dimer would tell us the prothrombotic state of the patient, and the CRP would tell us a little bit about the inflammatory status of the patient. And if the Corat score started rising, I think the mistake a lot of people made was to start steroids early. You do not need to start steroid between the 1st and the 5th day, unless the complications have set up and you don't know the onset of the illness. But otherwise, the right time for steroid initiation. In fact, the only drug that has really helped, but not directly in treating of the illness, but in reducing the complications that we saw, was steroids. And if it was initiated in the right amount at the right time, the incidence had become less. Wherever we have patient has already come with a complication, it has still remained the mainstay. Where there is prothrombosis, the anticoagulants was the mainstay. Where there is too much of inflammation, the mainstay was steroids. Remdesivir, all the other drugs had supportive uses, but I think the two main drugs were the anticoagulants and the steroids. And in case there is comorbid secondary infection, antibiotic cover, the question of using HCQ And the other vitamins is question mark, question mark. The use of azithromycin, yes, question mark again, risk. We have noticed that with the use of HCQ and azithromycin, there were prolongations to the QTC interval, which predisposes them for sudden death and cardiac tachycardias, ventricular tachycardias, and torsades. So those drugs were double-edged weapons. One had to be very careful if somebody had already initiated. And that's what we were doing very critical monitoring about on all our patients here.
Thank you. Dr. Kalra, any comment you have?
I just wanted, actually, you have partially, you have also asked him, patients who you are, whatever you have shared your experience about the hospitalized patients, what about patients who were in acute phase, did not manifest that time any cardiac problems, but in the follow-up, any cases which they develop some cardiac problem, dysrhythmias or other cardiac problems?
Yes, sir, a fair number of them, because those that were treated on an outdoor basis were self-managing at home. The guidelines were given to them, but if they did not follow the guidelines or report in time, then some of them would progress, because if, like I mentioned, if the patient, you have generally a patient whose relative has become COVID positive, and the next of kin comes to you and says, even I have become positive, then he comes to you for your advice. So since he's in the early prodromal period, they were not being admitted because there was shortage of beds during certainly the second phase, and they were being monitored at home. And they were on self-monitoring, and they would be reporting to us periodically from home to tell us about their saturation status. But periodically, if we found that the saturation kept on the downward trend, we needed to do quick investigations for them to decide, like I mentioned, the prothrombotic and the inflammatory phase. And if we found that by the time they came to us, the numbers had already gone up, then, like I mentioned, they fell into the 20% category, who would then manifest with some cardiac presentations or other. And a fair number of them did do it. And at that stage, there was no choice but to get them in somehow and monitor them more closely. But till they came to us and we could offer them a bed to monitor them carefully, yes, a fair number of them did progress, especially in the second wave with the Delta wave. That was the one that created maximum problems.
Yes. Any more comments from? I have a question. Now, I know you are working in one of the best setup in the country. Safi Hospital is equipped with one of the state-of-the-art intensive care, and you could offer probably you could detect and you can offer the treatment. But does the standard of care in relatively lesser equipped ICU would have changed the prognosis in these patients?
Yes, certainly. Yes, certainly. I think in that critical period, like I mentioned, I think what you people are doing is a fantastic job. I hope we don't have the fourth wave, but I think people, because this was a new infection and we didn't know how to deal with it. Now we're becoming a little wiser on this subject. Training our medical professionals at the grassroots level about making them aware about the natural progression of this illness, telling them what is the right time to do the right thing. What are the things that you don't need to unnecessarily add to the prescription burden to the patient? And then putting them under tight surveillance. But like I said, once the complication at the level which requires closer monitoring is required, I think at least a good bedside monitor and ECG machine would be helpful, and maybe an echo if you're talking about cardiac ailments. And if the people are trained adequately, now we're talking about telemedicine, I think we could create a lot of support of that kind, because I'm sure the mortality must have been much higher in smaller centers where people didn't even know. I think I was told that people didn't even know. I'm told in smaller villages where my carpenter comes from, he says, "Kisko malum hi nahi, aisa malum pada, isko 2-3 दिन 4-5 दिन पहले कुछ बुखार आया और suddenly बोला वो तो आदमी मर गया." So people didn't even know what hit them. I'm sure, yes, we have a long way to go in understanding all these newer, kind of infections and infestations that we are facing, and we need to educate our grassroots level workers, become aware and become cognizant of what is the best option that they have at their disposal, and try and see how best to use telemedicine to support these smaller areas.
Actually, Professor Bejan Mishra is also in our group, and maybe he can also ask you something about the policy which will help the lesser privileged hospitals to follow.
Dr. Gupta, your voice is not
Oh,
very high. Can you come closer to mic?
yes, I'm actually sorry. No.
Yeah, Professor Gupta, thank you very much. Thank you very much for giving me this opportunity. First, Dr. Iqbal, very nice meeting you and listening to you. We always get concerned that all these findings which we all discuss, how do we reach it to the common people so that, they are able to understand how they are able to get to that knowledge which is there from experts like you, and they highly depend on medical practitioners in the neighborhood to guide them. And sometimes now, you can get consultations on telephone, you can contact people in a faceless manner. We are getting more worried about the credibility of the information which is getting disseminated to the common people. How do we ensure that the information is through an expert channel like yours, and we reach out this information to the citizens? So I just wanted to understand that from you, because you are in one of the best institutions in the country, and how an institution like yours, playing that role. I just wanted to understand that.
First, with due respect, I think a lot of panic was created by our media. And I wish that we could have used that more efficiently in communicating rather than creating fear. The second, as you very rightly put, sir, there are institutions like where we are talking today that are taking the lead in trying to assimilate information, disperse the information. But I think it is being received by a very select group. At a national level, maybe Dr. Gupta may be in a better position because he's there at the national level. Create these fora where at the grassroots level, the people who are working get access to the information, like you rightly said. And it will be very specific to the kind of facilities that they have at their disposal, where we could talk that with this limited asset that you have at your disposal, you can still do a fairly good job in looking after these patients. And I think from time to time, in the event of a national catastrophe like this, we must, like a disaster management cell, spring into action. The medical fraternity should spring into action, and then do what is required to support the nation in transmitting and sharing this vital information from experts, from their experience that they have. There might be disagreements. Some people may think differently than what I'm thinking. But at least if the other person correlates with what the other person is talking and understands that, yes, I'm seeing something similar, he may be able to put it into practice.
No, very well said. Dr. Kalra, I'll just take 2 more minutes. I'll just take 2 more minutes. I can see that you have raised your hand. I was just going back to some of the videos when Dr. Agarwal, our friend, was there. And when I was going through those old videos, I was reminded today very much in terms of how you were explaining to us. And Dr. Agarwal would explain in a very simple language with diagrams, with making a common people understand, and he was accessible 24/7. The amazing thing was, like what you just now proposed, he didn't wait for anybody to tell him to do that. He just did it, on his own. And he did it in such a manner that not a single person, even today, the video ID of the Zoom, which Heart Care Foundation is carrying for all their events, is one ID. And there is no password. Anybody could reach at any point of time. But of course, the moderator allows the people to come in or not come in, But what I could see, people came back to me. Thousands of people have told me that, sir, ऐसा विकल्प कब मिलेगा कि कौन ऐसे व्यक्ति होंगे या कौन ग्रुप होगा जो हम लोगों को आसान तरीके से समझाएंगे at any point of time when we want to meet somebody. And in fact, you know, a camera continuously laga rehta tha. There used to be a camera in front of Dr. Agarwal 24/7, and he was online. But of course, he had his own priorities. But people understood those priorities, appreciated those priorities, but came at a time when Dr. Agarwal would allow them to speak or allow them to listen to him and explain in a very simple manner. That kind of a platform we should think of building. I mean, this is my only proposal and suggestion after listening to Dr. Iqbal today. You know, it's been an enormous kind of a source of information which you shared. I wish we can take it to the common people.
My
Thank
comments on this.
Just to echo your sentiments on that subject with Dr. Kalra's permission, I did hear one of Dr. K.K. Agarwal's talk where he just talked about the usefulness of a very simple investigation called the CRP.
Yeah.
And I think that became a benchmark for a lot of people to use in future to decide the inflammatory status. A simple test, easily doable. And I think what you said is very right. I echo your sentiments, sir. But I don't know who's going to take the lead. I think somebody from this platform who are now relatively easily available to do all this should take the lead, in my opinion. I'm still a practicing clinician. I still work 12 hours a day, but I'll certainly contribute my might from all the learning that I learned from my practice with anybody and everybody at any time. Thank you.
That's what I wanted to comment. I have never seen Iqbal to lose his temper. He's always very patient, very simple, very expressed in simple languages, simple term. All my patients who have gone to him, they came back कि बोले ऐसे भी डॉक्टर इस दुनिया में जो इतने आसानी से समझा सकते हैं. I think this is a compliment, and of course nobody can replace KK, but definitely we can fulfill his desire. And as he said, show must go on. So we must invite people like Iqbal Bhai to join our group and maybe help the common man. This is the mission of this group, so that we should percolate our knowledge and the elements to the people at the bottom also. That's our mission. Yes, Dr. Kalda.
Thank you, Dr. Gupta. Thank you.
Dr. Sethi is stuck up with some patients in the ICU. Probably he won't be able to join.
Okay, no problem.
And one question to Dr. Iqbal. Sir, as cardiac these problems are known even in asymptomatic patient who had COVID-19. So any protocol or advice you would like to give to the community in the follow-up patients who recovered COVID, when they should contact a physician, or any other protocol advice you give to your patients of COVID to just take care of these cardiac problems, which earlier they were not having, especially without any risk, or with patients who are at risk of getting cardiac problems, especially the elderly.
So I think I'll begin from the statement you use as asymptomatic.
Yeah.
Now, COVID is like any other viral flu that we've been talking, which is existing in this world for years and years. So a lot of patients may be COVID positive and they don't even know that they're COVID positive. They are incidentally positive.
Yeah.
And that is the group that we are worried about, because they are the ones who don't get the necessary surveillance. So and particularly like I mentioned, that family members of people who have become COVID positive, मेरे को तो कुछ नहीं हो रहा है, बुखार भी नहीं है, कुछ भी नहीं है, लेकिन सब लोग बोल रहे टेस्ट करा लो, तो मैंने टेस्ट कराया तो पॉजिटिव. Now I'm worried about this group of patients, and I keep on insisting on all of them that you must have a pulse oximeter, you must check your pulse rate, and you must check your saturation. Take your baseline saturation, and at least 3 times a day, it doesn't cost a penny. Monitor your saturation, write it down. If you find your saturations are dropping, that is the first telltale sign that you are heading for trouble. And like I mentioned, that at the end of 5 days, the fever, body ache, cough may go away. But the complications that the virus has been producing starts from the 5th to the 10th day and progresses depending on your natural immunity to handle the infection. And that is the group that requires surveillance and may land. Now, like I just mentioned, like Dr. K.K. Agarwal mentioned, CRP, a simple test. If there is an increase, it is a progressive rise in the CRP levels, it's a warning sign something is happening inside your body that you are not able to perceive. And therefore, we need to work you further up. Now, unless that kind of cooperation and coordination between the doctor and the patient is established, then it becomes difficult. And then, of course, the whole journey, you may show some inflammatory signs and recover completely. So maybe at the end of 10th day, your saturation levels are stable. Although you are asymptomatic, stable saturation levels, you are out of the woods. Hopefully, you will not get into trouble. Your saturation dropped and remains dropped. You must go in for further surveillance till either it returns back to normal, or if it goes downward, it's a wake-up call. You need to work around it. So these simple monitoring tests are the ones that we need to use. For the ones that are asymptomatic into inverted commas, they are asymptomatic from the basic presentation, but within the inside the body, turmoil may be happening, which may perceive only late if we don't keep them under surveillance.
Yeah, I recall Dr. K.K. Agrawal telling me about the CRP. Even when I was contemplating taking vaccine, he said, get your CRP done. If your CRP is less than 5, then only go for it. Otherwise, you work it on and then doing something. As a very good piece of yes. Yeah, Professor Chamkar, you want to say something? Now, Iqbal bhai, my question is, in patients those who are recovered fully from COVID, in those cases, what precautionary investigation they should do to make sure that they are not having any developing cardiac element, even at a younger age group or a later age group?
Dr. Saab, a clarification, when you say they have recovered, means what? They become COVID negative? Do I take it RT-PCR negative?
No, 6 months post-recovery. They are healthy otherwise.
Post-recovery. I think then there is nothing to worry, because it's like a viral flu. And the previous infection is not likely to create any problems. So from that point of view, no. But what we need to understand is that we've had patients whose RT-PCR has remained positive. I'm using the word RT-PCR, not the antigen. Has remained positive for 3 months and more also.
Yes.
Because the sensitivity of the RT-PCR is very high. And those are the ones, although theoretically we say you don't need to worry, you're not likely to transmit the infection, I would still be a little vigilant in that group.
Okay.
But once you have tested RT-PCR negative, then probably we don't need to worry. Now, unfortunately, for the future management, we're going to rely more on the lateral antigen or the COVID antigen. And the sensitivity and the specificity of the two tests are totally different. The parameters that the ICMR uses and the Western countries use for the RT-PCR are also different. So their tests remain positive much longer when we say you're already RT-PCR negative because you're less than 35. So those variables we'll have to make adjustments in understanding. When somebody from England calls me and says, my RT-PCR is 37, but they're saying you're positive and they're not allowing me to fly, there's nothing I can do. You have to wait that much longer. So those parameters, those variables, we must be aware. But once you're negative, from the previous infection, you don't need to worry. What I would worry about is, what happens if I've already become positive? Now, am I free? Can I go ahead and say, now COVID can't touch me? The answer is a loud no. It can still come and touch you. Whether you're vaccinated, whether you're already infected, because the virus keeps on mutating and your immunity is to the last strain of the virus. The new mutant strain, the immunity may be partial, may not be at all. So I think that understanding and knowledge must be there, because I know a lot of my patients that were positive became negative, and the first came and said, now should I take out my mask? That was because people believe that now I'm free, I'm already infected, I can't have COVID again. So I think, and you heard in the initial preamble, there are so many strains of Omicron that we are seeing. And whether there is cross sensitivity between the viruses, we don't know for sure at this juncture. So the safeguards still remain the same till the world clearly and loudly says that COVID is gone. But the way I am seeing it, COVID is not gone. Probably the next vaccine that we'll get, we have the flu quadri. I wouldn't be surprised if I hear the flu penta, where the fifth one is COVID. I believe that may be a possibility.
What you rightly said, COVID is not gone and we still have to follow the social distancing, safe behavior, and the mask. There's no
I
substitute.
hope.
Yeah, Dr. Jamkar, you wanted something?
I think that's okay. We had been quite wise, Dr. Iqbal's deliberations. Then you get more cautious, even if you don't have COVID, or even if you have COVID, you can't stop getting cardiac complications.
One of the worst things that COVID has done, particularly those that have suffered cardiac illness, is the fear, the depression, the anxiety. I think that has become a major source of concern for us. Because although we may on paper say that they've recovered partially or fully or not recovered, the second part is the one that is now, and not only the ones that have cardiac problems, anybody who became COVID positive or anybody who lost a near and dear one, if he becomes positive, one of the biggest problems that we face now is the anxiety. And like I said, if you hear a lot of wrong things on the media, that adds to the misery that people have. So we need to be very conscious about it. We need to communicate the right things in the right manner and reassure people, those that have become positive, that look, you don't need to worry. Most, like I mentioned, 85% of the people don't need to do anything. They become, in the Omicron, we don't even advise any medication except simple cough syrup and paracetamol, nothing more than that. So once you are aware and we share the right information and the right reassurances, I think this whole business of the mental illness that is being able to produce, that incidence should also come down.
I think it's a bit of a message to Professor Bejan Mishra to guide the media not to, like Dr. Iqbal has said, the media has been a little more vocal than what is required for such cases. And mental illness is a very important element which we are realizing now. I mean, as a surgeon, as a past 30, 40 years, we never realized the importance of mental illness associated with the disease. But now the entire concept has changed because of COVID. Yes.
You see, people like you, my suggestion is we should, develop a kind of a platform where whether the government listens to us or not, immaterial. Health is a state subject. All states need to be kept updated. Central government also needs to be updated. And you know that the media always likes to take up certain issues which will create either the eyeballs on the television channel or the readership in the print media. In order to do that and make that happen, I mean, my experience through my Jago Grahak Jago campaign and various other campaigns which I have been involved with the government is we have to constantly keep writing and keep the media also informed that we have given this input to the government who are supposed to communicate this to the common man or to the common citizens. As you know, during COVID, every day there used to be a briefing, whether it was the director of AIMS or whether it was XYZ, But nobody would talk in the manner like what Dr. Iqbal spoke today, and he's still conveying to us through various questions which we are asked him in a simple manner, which needs to be communicated. Like what he just mentioned, that people have some kind of a wrong notion sometimes that if you become a victim once, you will not get the virus again. All these kind of misnomers, misinformation can only happen, I think, when people like you all, who are practitioners, regarded, respected, and you carry a credibility behind you, you all should speak up and keep writing. Now, I know you all can't because you all are very busy, but there should be a kind of a secretariat like the Heart Care Foundation or say my organization called Patient Safety. I do not know how Patient Safety and Access Initiative of India Foundation can play a role. We get resources. It is not that we lack the resources or we lack the manpower. We lack credible information to be sent to us by credible people. We lack that. Let me tell you that. And I'm constantly trying to understand from people like Dr. Iqbal, how do we get constant information from you all so that I can make it public? Let it be on my website, but at least certain important issues, I'm compelled to write to the government and bring it to their notice. Whether they speak that to the media or not needs to be understood. But I can tell you, there are responsible journalists also in the country who write, who speak up, who cover healthcare issues. So if we keep giving them certain informations in the right manner, they will be the first one to carry it. It is not only commercial reasons which make them triggering writing articles or writing advertorials or things like that. But even credible information media is looking for, but from credible people. They will not, I mean, at least Bijon Mishra will not write to them about such information. I will not write. But Dr. Iqbal can write, Dr. Jamkar can write, Dr. Kalra can write, Dr. Ashok Gupta can write, because you all are known practitioners and you all are experts on the subject. So they will listen to you. And of course, we should take it up through a platform. So media, gets excited because they have to cover something every day. They're paid for that. So if they don't get something, they'll cover. Irrespective of who is saying what, they will cover. But we also need to debate on it, refute it at times, be bold enough to speak up. Even if the government may not like it initially, but most of the time I have seen they start appreciating what you are doing. And then they keep listening to you. Once they know that this man will never give up, they will listen to you and they will take it forward. So, help us in whatever way you all feel you all can. We are there. And like I used to keep Dr. Agarwal was on my board of my organization. We used to keep talking regularly. I can see Manisha Kukreja also here today, who is part of my board. So there are a number of people, who want to do good service, but we have to find a mechanism in terms of reaching out to the people, and which is very important. I'm just still struggling to understand how do we do that, but we are on it. We are on the job. Dr. Gupta. Thanks for giving me this opportunity to vent out my thinking about media.
Dr. Kalra, I just want to add whatever Dr. has been talking about. I think we need to amplify and extrapolate efforts of this platform, either on social media or by giving a press release or writing a letter to editor. So maybe once in a month, whatever points we are crystallizing, whatever points we want ordinary people to know, maybe either written letter to editor, maybe we can create a format of email of all big newspapers or social media, or maybe giving a press release to PTA or something. I think if we do these efforts, our efforts of whatever service we are doing to COVID would reach to the masses.
I think Dr. Kalra, what Professor Bijon Mishra and Dr. Jamkar has said, and now with the current increase in the telemedicine forum also, if a guideline can be made by expert like Dr. Iqbal about the prophylactic and preventive cardiac care in COVID, and what it could be treated as a warning symptoms and what should be not be ignored, and that can, through the telemedicine, it can percolate it to the common people. I think that will be a great service. If
Yes,
we can use this platform with Dr. Iqbal can write up, and then we can share some of the details on a platform, that will be a greater service to us. And if
Okay.
of course, Dr. Iqbal, I'm sure he will be happy to help us.
Yeah.
Are we almost coming to the end of the time?
Yeah.
Dr. Iqbal, thank you very much. And if you have to tell us some point how we should behave as a group. Ours is a group of experts in the round table, and we presume that we discuss very important topic every week, and then we carry it forward, and some of the suggestions are being sent to the competent authorities.
Maybe you people said this is the 98th session of yours. So you've been there for a very, very long time, and I'm sure with this kind of leadership, I expect a lot of good things will happen. This country needs all of it. And we need to keep on going, increase the number of platforms that are doing this more on a regional basis so that, the transmission is easier, more people can be covered.
Yeah. And all these discussions, these videos are available in the public domain on Dr. KK Agarwal's YouTube page.
I think
Thank you, sir.
great.
Can we conclude now?
Yeah, please.
Yeah. Thank you, Dr. Iqbal, for your wonderful information given to us. And thank you all the participants. See you in the next roundtable meeting after.
Thank you.
Bye.
Thank you.
Bye.
Thank you.
Bye-bye.
Very
Thank
good.
you.
Nice meeting. Nice meeting.
मम्मी डांटेगी फोर रब फोर
सर्फ एक्सेल मशीन स्पेशलिस्ट जिद्दी दाग निकाले मशीन में ही सर्फ एक्सेल मैटिक लिक्विड।